Back, recording in process. Clinical problem solvers, how's it going? Another Friday VMR from the West Coast, the best coast. Is that what you guys say here on the West Coast? I can't say that. Robbie will get mad because this is global VMR. Every coast is the best coast. It's nice to see all your lovely faces. Tiago, how are you, my friend? Robbie. I see we have a special guest in the audience who's going to be presenting today. But let me pass the mic to Robbie to introduce our special friend.
Oh, I'm delighted to have Sammy here, but also a little scared. I was telling Rez that Sammy always has us on the edge of our seats. Sammy is one sec. Sammy has been a member of the VMR community since its very inception, and actually one of our most ardent supporters on Patreon too. We actually have gone to hang out with Sammy a couple of times closer to his family in Austria. He actually just presented a case to us on Wednesday that will hopefully be released on Patreon. That is an absolute doozy. But Sammy is actually a final year student in the University of Graz in Austria, and is just an outstanding human being who can smile from ear to ear, according to him, for 30 minutes after nerding out to VMR. And we're delighted to have you here, Sammy. So go ahead, say a quick hello. Tell us what you've been up to recently, and we'll jump right in.
Hello, guys. Can you hear me?
Yes.
Okay, sorry, I was just kind of having the connection problems. Yeah, thank you so much for having me. My name is Sammy. I'm a last year medical student from the Medical University of Graz in Austria. And yeah, delighted to present the case today. I just finished today my Med-Peds rotation, and now I'm going to general surgery starting on Monday. Yeah, I'm not that good in surgery. We will see what happens, but never not learning.
Sammy, you're always welcome here. I just might be a little bit less gleeful if you present a pediatric surgery case, which seems to be like the perfect combination of your last two rotations. But before you take us to the case, I also wanted to say hi to Leah, who I see here in the audience. Hello, thanks for joining us.
Hi, I'm excited to join. It's my first time officially joining you guys.
Amazing, it's a delight to have you. All right, Sammy, you ready to rock and roll?
Yeah, sure. Okay, let's see. This is the case of a 77-year-old male with diarrhea since 2 months. And a little bit more on the history of the presenting illness. He complains of non-bloody, non-mucus diarrhea 4 to 5 times a day, and also persistent during the night. He denies abdominal pain, nausea and vomiting, dyspnea, syncope, lightheadedness, reduced appetite, fever, chills, or night sweats. He also denies arthralgias, myalgias, or lymphadenopathy. So that's it for the first aliquot.
Wow, Sammy, I was telling Robbie, if I had to guess where we are, it was going to be an infectious cause, because the two cases you presented to us in the past, both were rare infections. I don't want to spoil it for the audience, but maybe I can take a quick stab here and then ask Robbie to just add whatever he wants to my initial discussion. Many times when we're solving a problem, we try to identify the problem that we're solving. And sometimes it's difficult to identify the problem. Imagine this, someone tells you to climb a specific hill. If you identify the wrong hill, you're gonna reach the wrong destination. Here, Sammy has made it very easy for us to identify what hill we're climbing. So this clinical problem is diarrhea. There's no other symptoms. So the signal versus noise here, we can zoom in on the signal. So now we have to apply our framework to diarrhea. And maybe I'll start with the framework and then pass it to Robbie to fill in the gaps. we mentioned this over and over again, and I think it's worth emphasizing that tempo is key. So when you have 2 months of diarrhea, you're in the framework of chronic diarrhea, not acute, because most causes of acute diarrhea are infections that are transient in nature. But here we have to zoom out from that and share our framework for chronic diarrhea. And that first step in determining our next approach is whether we're dealing with inflammatory diarrhea or non-inflammatory diarrhea. And here, when we use the clues that Sammy has given us, and it's very difficult, by the way, this is only based on aliquot 1, only based on the HPI, because there's other data that's going to help us distinguish inflammatory versus non-inflammatory, like the white blood cell count, for example, like the temperature. But based on aliquot 1, it's non-bloody, non-mucousy, and no fever, no weight loss. So we could go into the category of non-inflammatory diarrhea. And when you're in that category of non-inflammatory diarrhea, the next step is whether the stool osms are elevated or not. Not that you need to send those, but that's really how we create the framework. Why don't I pass the mic to Robbie to sort of fill in the gaps there?
I love it. I have nothing to add. I think that's really the analysis that we should have. And I remember a case that we had on Thursday VMR with Charmine, where we were actually I forget what the diagnosis was, but I remember that we were fooled that actually the diarrhea turned out to be just a small part in an otherwise important systemic syndrome. So I'm right there with you in trying to figure out what the mechanism is, and also trying to make sure that we're not fooled by diarrhea being a small part of a respiratory issue or something else going on outside the GI tract. And yeah, I think we're going to be on the hunt for any signs of inflammation. And I think early on, an osmotic diarrhea is a little bit less likely because it seems to persist without ingestion of osms, which is a leap. It's not what we heard. We heard that it persists during the night. And the assumption that we're going to make is that the patient, unlike me, doesn't wake up and snack in the middle of the night. So that's a big caveat as I finished my apple snack for VMR. But yeah, if there's no ingestion at night, we can move pretty quickly to either inflammatory or secretory. And knowing Sammy, have a little bit of a don't be fooled bias, and the don't be fooled is the diarrhea is actually a small part, and he's going to next tell us that the platelets are 12 and that the creatinine is 7. So we'll see. All right, Sammy, back to you.
Okay. Yeah, he denied any abdominal pain, just for clarification. There was a question in the chat, and also no tenesms. So for the next aliquot, he had a past medical history 18 months ago. Grade 3 adenocarcinoma of the prostate was diagnosed with bilateral hydronephrosis, renal failure due to retroperitoneal lymphadenopathy, and disseminated bone metastases. His PSA at that time was over 1,000, and he was treated with transurethral resection of the prostate, received bilateral urethral splints and medical therapy. And due to this therapy, he had marked improvement. His PSA dropped to normal limits, and the lymphadenopathy diminished or was gone after the treatment. And otherwise, he was healthy. He had no previous other history. For his medications, he takes bicalutamide, which is an androgen receptor antagonist, then Leuprolide, which is a growth gonadotropin releasing hormone agonist, just so you don't have to Google it like I did, and then also MAP. I will put their names again in the chat. For the family history, non-pertinent, social history, he's a retired businessman. For health-related behaviors, he has a history of 15 pack years, no alcohol or drug use. He also doesn't have any allergies. Maybe you want to comment on that a little bit, or should we go to the physical exam?
I'll just share a quick reflection, Sammy, and pass the mic to Reza, see if anything to add. I think that prostate cancer here does change the calculus. I think it's not surprising that a patient who's a 77-year-old man has advanced prostate cancer. It's the most common cancer in men. And it's unfortunate that it has caused local and disseminated complications. And I think that in patients with malignancy, medications are a notorious cause of diarrhea. So while I don't actually know whether these medications are implicated in diarrhea, I certainly would be looking it up. If you're extending cancer plus diarrhea in general, the meds are the biggest offender, and then the possibility that radiation is at play, causing radiation enteritis. And the last but least likely hypothesis is that there's some sort of fistula between the urinary tract and the colon, causing a colovesicular fistula. And this diarrhea may not be diarrhea at all, but rather urine coming from the rectum. And I've actually seen that a couple of times already. And I would think we had a VMR case of a colovesicular fistula that presented the other way with feces coming into the urine, but it definitely can go the other way around. So yeah, I think this changes the calculus a little bit. I think the probability of a tangible diagnosis, which is not always true for chronic diarrhea, has emerged in the context of this therapy. And you want to make sure it's not medication related, the most morbid of which is immunotherapy related. And then radiation is a big annoyance for a lot of patients with tumors that are radiated near the GI tract, and then rarely think of something anatomic. But those are my reflex thoughts, and I'll pass the mic to Prof. Rez to anything to add, and then we'll move on.
That's brilliant. Zero to add.
Okay, perfect. He had 15 back years, not 50, 1-5. For the physical exam, his temperature was 36.8, his heart rate 98 per minute, blood pressure was 110/70, respiratory rate 14, SpO2 97% on room air, and his BMI was 22. For his general appearance, he was awake, alert, and appeared dehydrated. His heme exam was unremarkable. Cardiovascular, there were no murmurs, rubs, or gallops. For pulmonary exam, he was cleared to auscultation bilaterally. Abdominal exam was also unremarkable, not painful to palpation, non-distended, regular bowel sounds, no organomegaly. And the neuro exam, skin exam, and extremities were all unremarkable. You want to comment that, or let's proceed to the labs?
Sammy, I can make a quick comment because one of the main questions we're trying to answer here is whether the patient's inflamed or not. And again, we're getting no signal to point towards inflammation, and we're getting no signal that any other organs involved, like the lung, the heart. So right now, what's being prioritized is diarrhea as the main problem and a non-inflammatory cause and a non-osmotic cause, based on what Robbie said. Looking forward to the next aliquot.
Okay, maybe the labs will bring a little bit more to discuss. So,
Sammy, you always say that, my friend.
For the leukocytes, there were 12. They were 12.8 with a normal differential. Hemoglobin was 10. Platelets were 685, so 685,000. His sodium was 131. Potassium was 2.1. Chloride was 108. Bicarb was 14. BUN was 64. Creatinine was 3.8 with a baseline of 1.3. Glucose was 110. Calcium and phos were normal. AST was 20, ALT 23, GGT 58, alkaline phosphatase was 263, and bilirubin was 1.2. Total protein was 7, albumin 3.1, LDH was 522, CRP was 3 with an upper limit of normal of 0.5. And then a UA showed 75 milligrams of protein and sporadic erythrocytes. A fecal occult blood test was negative. And for the chest X-ray, it was unremarkable, and an ECG showed normal sinus rhythm with tachycardia.
Oh, Robbie, should I go ahead? Go ahead.
Maybe I'll just tackle the CBC and leave the
Deja vu, my friend.
right, but I guess the other way. So the CBC is telling a story, and that story is of chronic inflammation. And the way you might come to that conclusion is to say the most dominant abnormality is the thrombocytosis. It's very unusual to see platelets this high. It's not so unusual to see a mild leukocytosis and a mild anemia in somebody who has cancer who is this sick. And so what does the thrombocytosis represent? Without bias towards base rate, you might just say the causes are either primary bone marrow diseases or reaction to something systemic. And then when you factor in the base rate, you recognize that systemic causes are overwhelmingly more common, about a ratio of 9 to 1, regardless of how high the platelet count is. And that reaction is often due to the trusted triad of inflammation, which is infection, malignancy, and autoimmune disease. But as Reza has heard me say many times before, it's not just any infection, autoimmune disease, or malignancy. It's usually occult infections like abscesses or granulomatous disease. It's almost always seronegative diseases like inflammatory bowel disease, or solid malignancies, much less common than liquid malignancies. In fact, the only liquid malignancy that can do this is a myeloproliferative neoplasm, which would be less compatible with the presentation because it's rare, and 2, because it usually is associated with polycythemia, not anemia. So I think what we found evidence for is actually to have to repivot a little bit. We've reconfirmed the time course. Thrombocytosis is almost always chronic. It's very rarely acute. And we've now found a little bit of evidence of inflammation, and that evidence of inflammation is in that thrombocytosis. And so I think most acutely, you'd probably be worried in a patient without much exposure to granulomatous organisms based on his presumptive residence in Austria or Central Europe. You'd worry about an abscess in that space. But then secondary concerns would be malignancy, which he's already proven he can have. And third would be, does he have inflammatory bowel disease at the age of 77, which wouldn't be completely unheard of. I'll pass the mic to Rez for the rest of it.
That's beautiful. Sammy, quick question for you. The GGT, is that normal or is that elevated?
That is normal.
That is normal. Okay, that's really helpful. And I'm going to do, and I don't know if we've ever done this, but in VMR cognitive autopsy, before we even get to the end of the aliquot or the end of the case. And what I mean by that is, you know, we should have taken the lack of any inflammatory signs in the history and the physical exam with caution. Why caution? Because of the medications the patient's on. I don't know exactly how these meds affect the patient's ability to mount an appropriate immune response, but you can easily see that this patient probably doesn't have the same immune system as someone who's not on these meds or someone who doesn't have a history of cancer. So I probably should have added that qualifier when we were thinking inflammatory versus non-inflammatory to say that let's be cautious here because of the medications the patient's on, as opposed to just dismissing inflammatory diarrhea. And now we have one lab value, but never let one lab value sway you towards inflammation, though it's a great possibility and we're open to that hypothesis. These labs are really interesting. You have to be cautious here. Don't jump and say this patient has a metabolic acidosis because the bicarb is low. I bet you the patient does. I bet you that does. But in all other circumstances, you may have a little bit of a low bicarb, but you need a VBG to interpret an acid-based disorder. Because what if this patient had a history of COPD based on the smoking that we haven't diagnosed and has a PCO2 of 70, and this bicarb is what we would expect? What makes that unlikely is two things. One is the potassium And 2 is a history of 2 months of diarrhea. And by the way, diarrhea is weird because like the specific definition of it may not be what the patient is reporting. Like if you ever have loose stools, you'll say you have diarrhea, but that may not quantify exactly for the strict definition of diarrhea. But the potassium and the history tells me that even without a VBG, this patient has a metabolic acidosis. But actually, before I interpret that, Sammy, do you actually have the VBG on this patient? Because I think it would be great to look at that VBG and know what the pH is.
I sadly don't have a.
Oh, no, don't. It's totally fine. Thank you so much. So what we have here is when you're interpreting an acid-base disorder, the one acid-base disorder you can always with confidence make without a VBG is an anion gap acidosis. Here we know the patient doesn't have an anion gap acidosis. So I'm betting the pH is low. I'm betting this is a metabolic acidosis, and I'm betting this is a non-gap metabolic acidosis because of the history of diarrhea. When you have a non-gap metabolic acidosis, many times you'll send the urine anion gap, and if it's negative, it tells you it's from the GI tract. You're losing bicarb from the GI tract. Remember, negative, so gut tip. But here with the renal insufficiency, there might be a component of renal injury also contributing to this non-gap metabolic acidosis. The hypokalemia is consistent with diarrhea. They are losing it from the GI, you're losing volume from the GI tract. You're activating the renin-angiotensin aldosterone system. Aldosterone is secreting potassium and leading to this hypokalemia. And the hyponatremia, you're contracted, so you're losing volume, and therefore you likely have hypovolemic hyponatremia. So all of this confirms the chronic diarrhea this patient has. So what other labs can we use here? The alk-Phos being elevated is probably reflective of the prior bone disease that this patient has had with their underlying metastatic prostate cancer. The only other lab value that is jumping out here is the LDH and the CRP. So if the platelet counts were one clue towards inflammation, the CRP is quite mild, the elevation, but is another clue for us to step back and consider inflammatory causes of chronic diarrhea. And then the LDH, we have to layer on the LDH. We have a pyramid for LDH, and we start with hemolysis. There's no evidence of hemolysis here based on the bilirubin, the AST, and this hemoglobin being low is unlikely to reflect hemolysis. The next layer is there infarction of an organ, be it liver, kidney, lung. No strong evidence of that yet, though I'm still open to that possibility. The bottom of the pyramid is lymphoma, but Robbie told us the platelet count of 685 probably makes that unlikely. So you have to entertain the possibility of a solid cancer. Could this patient be so unlucky to have two solid cancers, like adenocarcinoma of the GI tract that now has metastasized, causing diarrhea and an elevation in LDH? It is a possibility, but I think we have to think about inflammatory diarrhea. So how do we do inflammatory diarrhea? You have to just think about the eyes. Is it an infectious process? Is it inflammatory bowel disease? Is it an infiltrative process like cancer, eosinophils, and such? IBD is unlikely, though remember you do get that second peak late in life. For Crohn's disease, it's bimodal. So young people, and once you hit like 70, I believe, is when you get the second peak. It's just not as large as that first peak when patients are 20. But the patients on medication that should be immunosuppressive, I'm not sure how that alters the post-test probability of IBD, but I think that's probably less likely. So now we're contending with infection or cancer. And if we are dealing with infection, just based on the tempo of disease and based on that platelet count, it would have to be an atypical infection. Meaning, could this be a mycobacterial infection? Could this be a fungal infection? Or could it be, some kind of atypical bacteria? That is really where I'm at. As far as like what I would do next in this patient with this presentation is I would send for stool studies for these atypical infectious processes. I think a colonoscopy might be extremely fruitful here, and maybe even some kind of cross-sectional imaging to see if there's any other clue. Robbie, I just talked for a long time. Anything, what are your thoughts? Any other thoughts to add to that?
I think the only issue of you talking so much is I might go into an arrhythmia of joy, but otherwise
Yeah, right.
yeah, I had nothing to add. I only just wish you ended these like just amazing spiels with putting your sunglasses on that I got to see. Charmaine and I got to see this morning. That would just be very fitting of Hollywood Red. And Sammy, back to you.
Oh, he's putting them on. Nice.
Look at that. Isn't he just screaming LA? It's perfect.
That's Vin Diesel. Okay.
Great.
For the next aliquot, despite rehydration therapy and potassium substitution, potassium only reached levels of 2.8, and the creatinine only persisted at 1.6. He had, during the whole hospital course, persistent refractory diarrhea. Azithromycin and metronidazole were ineffective, and also loperamide showed no effect. For his stool cultures were negative. 3 times testing for ova and parasites was also negative. HIV was negative. And serum electrophoresis revealed polyclonal gammopathy. And that's it for this aliquot.
Yeah, Sammy, I think this aliquot is really illustrative, and I'll just kind of ramble and ask Rez to mop up after me. I'll say that I think you have to be very careful with the conclusions that we make when we say we're hydrating somebody and their dysfunction doesn't get any better. Their kidney dysfunction doesn't get any better. And more practically, at least for us in the United States, we often say, oh, we diuresed the patient and their heart failure didn't get any better. And the key question is, did you diurese them enough? And the more practical question here in this case is, was enough hydration given to this patient? And I think given how much he appears to be losing, I wouldn't be surprised if a mechanism, at least a partial mechanism of his persistent kidney injury is the fact that he needs more fluid. It's also unfortunately not uncommon to have non-specific kidney dysfunction, namely acute tubular necrosis as a result of prolonged prerenal injury. So before we get fancy smancy and say, hey, this is a diarrhea plus renal syndrome and invoke things like amyloidosis and maybe even oxalate nephropathy from GI malabsorption and IgA nephropathy from GI disease, all sorts of things. I think the practical assessment here would be, he went from 3.8, he's down to 1.8, and he could have ATN. So I'm not going to invest too much into the kidney dysfunction, but that should be tempered with the fact that you should closely analyze the urinalysis and the microscopy, because if all of a sudden you start to see crystals there, or all of a sudden you start to see casts there, you should reassess. And the truth is that the most valuable thing here is the HIV test. HIV can sneak up on you and commonly presents as CNS syndromes, respiratory syndromes, or GI syndromes. And here the fact that it's negative is very helpful. And I'll just cut to the chase. When you have inflammatory diarrhea, you need to take a picture. If there is overt inflammation, namely the thrombocytosis here, the best way to make progress is to see where the inflammation is. And you can make a lot of progress by describing the inflammation as a diffuse colitis or as a vascular predominant colitis, or rather as a focal mass. So I'm not too surprised that his imaging, that his labs are not revealing, and really would say inflammatory diarrhea, chronic inflammatory diarrhea. Acute inflammatory diarrhea is an infection until proven otherwise. Chronic inflammatory diarrhea, take a picture. What kind of picture? Take a picture from the outside with a CT scan. It's much faster, but often you need to take a picture from the inside using your own eyes with a colonoscopy. The blood work is very productive in patients who have osmotic diarrhea or secretory diarrhea, but you often need to look to see what the inflammation is from the outside and then from the inside for inflammatory diarrhea. Prof. Rez, I know you had to pick up that phone call, but yeah, I'm curious, any remnant thoughts that you have or comments before we get the next set of data?
0.
Okay. He also received serum and urine immunofixation, which was also normal, and his light chains were also normal. His TSH was 0.01. FT3 and FT4 were normal. His stool Osm gap was 24. And for additional data, his PSA was normal. His tissue transglutaminase antibody was normal. HLA DQ2 and DQ8 were also normal. Calprotectin and elastase in stool were also within normal limits. For imaging, it was only this is an old case, and at that time only an MR enterography was performed, which showed fluid-filled small bowel loops, retroperitoneal lymphadenopathy, no masses in liver, pancreas, or spleen. Yeah, and that's it
Wow,
for now.
Sammy, you are such an expert presenter. What a case. And I think what I'll do is I'll leave the MR for Robbie to discuss, and then I'll talk about the other data. The question becomes, is the thyroid disorder, we know thyroid can masquerade as many disease entities. Could thyrotoxicosis explain this patient's presentation? Well, where's the thyrotoxicosis? The T3 and T4 are normal. So this would have to be, by definition, subclinical. And there's no way that this presentation with this platelet count, this LDH, this tempo, this degree of electrolyte abnormality is due to subclinical hyperthyroidism. So you always have to be cautious when you get lab value back. You have to ask, does it fit and match the illness script? And this is why we reflex the TSH to see what the free T4 and T3 are. The osmolar gap is consistent with what Robbie said on aliquot 1, where he said, since this patient is having diarrhea at night, it's unlikely to be osmotic in nature. This confirms that. So we're dealing with a non-osmotic chronic diarrhea. The DQ28 and DQ2 are for celiac disease, and both of those being negative. And just this presentation is less consistent with celiac, but you have to be very cautious because celiac can have a lot of extra intestinal manifestations. And the calprotectin is just another way to see if we're dealing with some kind of inflammatory diarrhea, which I don't think we are in the sense of some kind of infection or inflammatory bowel disease. In any case, I think what this data does for me is really make me wonder, what's going on in the intestines, and is there something that we're missing?
I can guarantee you one thing: there's definitely something we're missing. I have no idea what it is the problem. Yeah, I completely agree with that analysis, Rez. And to loop in the imaging, I think it's very tempting to say, oh, there's disease in the small bowel, so it must involve the small bowel. And I think if that were true, you would immediately eliminate ulcerative colitis as it is limited to the colon. You would probably also eliminate all causes of secretory diarrhea, because by definition, all secretory diarrhea causes are causes of the colon, where it's basically the colon is just like the distal convoluted tubule and the collecting tubule. All it does is handle water. So if we say that the small bowel is involved, then we rule out UC and we rule out secretory causes, like some of which are very common, like microscopic colitis. But I don't know. I think it's totally plausible that diarrhea just makes the small bowel, diarrhea of any cause makes the small bowel look very funky. And I think my analysis of this case is very biased by that platelet count. And I think if it vanishes away, if it honestly, like he's been in the hospital at this point for a period of time, and so that thrombocytosis vanishes away, you'd have to reassess, because if we have our three mechanisms up visually, we're like, there's osmotic, ruled out by osm gap, secretory, ruled out by small bowel involvement, you're left with inflammatory diarrhea. And further support of that inflammatory diarrhea would be present if that thrombocytosis persisted. And we thought about inflammatory diarrhea in many ways. We've ruled out in the many causes of infectious inflammatory diarrhea. A calprotectin is very good for inflammatory bowel disease. So are we, so that's infection, autoimmune, and then malignancy now becomes important to think about. And that malignancy can be GI lymphomas or amyloidosis involving the GI tract, which you need a biopsy for. And then you might have to scrutinize and say, wait, am I just dealing with diarrhea and infection or inflammation somewhere else? And that's where I go back to this notion that, hey, we know he has a lot of anatomical disease that is retroperitoneum. We know he's had cancer there, he has lymphadenopathy there. Do we need to look at his pelvis better? So I think, where am I at? I think you've ruled out secretory, you've ruled out osmotic. And is there a non-infectious, non-IBD inflammation here? Or is the inflammation simply the result of anatomic irritation of both the GI and the GU tracts in the pelvis? So what would I do next? I think the MR was great, but maybe it was too focused on the GI tract, hence the name enterography. And maybe we need to zoom out and look at the bigger picture of the abdomen. It's like getting an MRI pituitary protocol and missing the cortical-based lesion in the brain, So that's what I'm worried about. But my handle, honestly, confidence level is very low here. I don't think, if I were taking care of this patient in real life, I don't think I'd be sleeping very well.
I love how you ended on that. I don't think I'll be sleeping.
I would go back to my midnight snacks and the reasons why I snack at night. Full circle.
Okay. His urinary potassium was 13 millimole per 24 hours. Calcitonin, gastrin. Are we scribing? Oh, okay. Calcitonin, gastrin, 5-hydroxyindole acetic acid was normal. Chromogranin A was 22, with a upper limit of normal is less than 10. EGD was performed, which showed reflux esophagitis. Otherwise unremarkable. Colonoscopy was performed as you suggested, and multiple biopsies were taken. Basically, it was unremarkable. Congo red staining was negative. Whipple PCR was negative. Also negative for microscopic colitis. And that's the last aliquot.
Wow. This aliquot, I think, is very, very helpful. Why? Because we have a signal now as to what might be causing this patient's chronic diarrhea. And something, I have to be cautious with is when we send the lab markers for neuroendocrine tumor, it's not something that we review on a daily basis. Recently, we did an RLR where I presented a question to Robbie where the crux of it had to do with the urine chloride, but it's not something I think about often. So I had misinterpreted it, and my mind went to something that I love thinking about, which is urine sodium. So I got the answer wrong, but Robbie got it right because he paired bicarb with chloride. So here we have an abnormality, we have a red front, chromogranin A. And what Sammy was telling us is basically, does this patient have a neuroendocrine tumor? And I think when you get to this stage of a case where you have inflammation, you have chronic diarrhea, you have to consider these secretory causes of diarrhea. And this is when it would be appropriate to send the levels. And not all patients with neuroendocrine tumors in the GI tract have any evidence in the liver. No evidence, even though many may start with a hepatic mass, which then prompts you to think about, secretory diarrhea and evaluate the upper small intestines. And the MR enterography isn't 100% sensitive in ruling out small lesions. In fact, in upper endoscopy, looking at the small bowel isn't sensitive enough. There is one test that's the most sensitive for these neuroendocrine tumors, and it's a fun test to try and pronounce, the Dotatat scan. The Dotatat scan is extremely sensitive and extremely expensive. In fact, it's like almost impossible to order where I was. So I think, Robbie, let me just be honest. I think I'm most concerned for a neuroendocrine tumor. And I'd love for you to maybe elaborate on the different types and where you're at.
Can I please ask you to say that one more time? What is it? What is it? A what?
Dotatat scan.
Oh my gosh. Okay. Oh, why does anyone come to this? I don't understand. Why does anyone come? That's amazing. I've never even tried. I've read that word. I've never even tried. You're my hero. Yeah, I agree. I think it's hard not to use this test as signal of a neuroendocrine tumor. And I think I don't know enough about it. I think as a general reasoning, Pearl, it seems to be mildly elevated, so you don't want to be too distracted by it, but you can't not follow that lead, given how devoid of other leads you have. So I think in terms of what you could do next, I do think that the scan that Reza mentioned is probably a very good idea. And again, you'd have to step back and say, well, why is this patient anemic with a negative guaiac and has thrombocytosis? And that gives me a little bit of pause, because the neuroendocrine tumors are very silent. They're devastating, but they're silent. They don't usually cause this degree of inflammation. So the inflammation may be something that we're over prioritizing, and you might say, wait, look, the CRP is 3. Don't worry too much about inflammation. In which case, a neuroendocrine tumor makes a lot of sense. Yeah, so I'm fairly in this camp of pursuing a neuroendocrine tumor, but also tempered by the possibility of an anatomic issue in the retroperitoneum. And I don't know where I'd go. The actionable step for me on an individual level is to look up the test characteristics of chromogramin A and see if that actually, this is like, boom, it's done. But in real life, you'd probably be leaning on your GI and hem-onc and maybe even endocrine experts. That's where I'm
Robbie, can I ask you a question? A thought that I just had, and
Yes.
another in-case cognitive autopsy. With the platelet count that we've been emphasizing for inflammation, could it be that this is just, a consequence of his prior prostate adenocarcinoma, and is just taking time for it to downtrend, and he's hypovolemic? It's so interesting the way you can view this case and how we view it when we get subsequent data. Because when we didn't have the or any, it has to be viewed as a signal, because we can't miss, one of those infectious causes, et cetera. But I actually don't know the tempo of when you expect the platelet count to sort of improve after treatment of prostate cancer or solid cancer.
I couldn't agree more. I think that's an excellent point. I don't know the answer to that. I think one thing that deserves highlighting is what Franco just reminded us, is that sometimes patients with prostate cancer can get neuroendocrine differentiation of their prostate cancer. And is that another reason why the chromogranin A may be positive? Actually, we see that quite a bit at the VA. We see a lot of patients with prostate cancer, and they break down into small cell prostate cancer, which is a devastating diagnosis. But yeah, this is a really, really tricky case. I'm curious where it went in.
Yeah, amazing discussion, guys. I just enjoyed it so much. A VIP level returned markedly elevated. Sadly, the patient developed AFib with RVR and sepsis from a central venous catheter, was admitted to the ICU and refused further workup, and sadly passed away. An autopsy was performed, which showed retroperitoneal lymphadenopathy, bone metastasis, and remnant of prostatic tissue, and 2 small lesions in the liver. The histology of the prostate showed an adenocarcinoma and poorly differentiated carcinoma, so 2 types. And the immunohistochemistry of the liver metastasis was positive for synaptophysin and VIP, and it was considered a neuroendocrine tumor in the liver. Yeah, and the most likely final diagnosis was Werner Morrison syndrome due to VIP expressing tumor tissue in the liver, most likely from neuroendocrine differentiation in post-treatment prostate cancer. So Franco, that was just amazing that what you wrote in the chat. The clinicians writing this case down from our university also thought that that was the most likely diagnosis. And yeah, I was just so perplexed reading this. Yeah, what are your thoughts?
Well, Sammy, my mind is blown. Before I pass the mic to Robbie, I'd love for you to just reflect on what you learned from this. But can you tell me the syndrome again? I actually didn't know prostate cancer can differentiate into neuroendocrine tumor, and I never heard that syndrome before. Can you mention it again, the eponym?
It's the VIPoma, and I don't know if it's only in German, but it's called Werner Morrison syndrome. Yes, I don't.
Awesome. I definitely heard of VIPoma, but not the second part.
Yeah. For
Anyway, Mike, to you, Sammy, what did you? Oh, I'm sorry. First, let's maybe hear from Robbie, and then hear from you, Sammy.
I just want to hear from Sammy. What a mind-blowing case. I think, you know, you in medicine you're constantly humbled. One, I think Franco's knowledge of this case is amazing, and you know where I stood was I've seen actually 2 or 3 patients who got small cell carcinoma as a consequence of their undifferentiated prostate cancer. And it's so amazing to learn medicine that actually there's nothing maybe unique about small cell. It is maybe just neuroendocrine dedifferentiation that's the real concept. And I really look forward to learning more about that. I had a patient who had prostate cancer and then had small cell differentiation, and then also got paraneoplastic encephalitis from the small cell. And I will always remember him and his wife. But today it's a little bit fascinating to learn that small cell is just an example maybe of the kind of the real concept is prostate can dedifferentiate into a neuroendocrine tumor, and it can be a VIPoma or a small cell, which is just. It just goes to show you how absolutely humbling medicine is, and how even when you learn something fascinating, like, oh, prostate cancer can become small cell, you would never imagine that a couple of years later, you'll learn even more nuance to that already very nuanced point. And so this obviously is a devastating outcome to this patient. And I think it reminds me of 2 things. Our journey into learning in medicine is never going to end. There's always more and more to learn. And 2, when you gather as a group of people with Sammy bringing this amazing case and with Franco bringing his pre-existing knowledge, we all are elevated to such a higher level. So I hope despite Reza and I's clownery that you continue to come to VMR to hear the DOTATAT scan and many other things. All right, Sammy, back to you.
Yeah, I have to say my favorite moment was Reza saying DOTATAT. Really have to admit to that. And for the case, I really didn't know that due to the treatment that the tumor can differentiate into another tumor and then produce hormones, which is well described. And lastly, I also really like the point about secretory inflammatory diarrhea on the one side, and then negative calprotectin in the stools, which pushed us more to a secretory diarrhea, and then with the unremarkable colonoscopy. Yeah, it was quite amazing, and I wanted to share it with you, and you did so great. It was a lot of fun.
That is incredibly kind, Sammy. Thank you. I will remember this case forever. I have a lot of reading and reflecting to do, and I may have already started by Googling some things, but I will temper myself to re-listen to this case by the lens of the one and only Rafa Medina. Take us home, my friend.
Hi, everyone. I just wanted to say a huge shout out to Sammy. Such an incredible case. Thank you for bringing this. Thank you for bringing this to us. Thank you, everyone who joined us today. Thank you, Ravi. Thank you, Reza. So we started this case with chronic diarrhea, and Reza reminded that first, when we're dealing with a clinical problem, we have to first identify the problem itself. So which hill will be climbing is the first question that you have to make yourself. Then tempo is clean hill, because we saw that this patient had 2 months of chronic diarrhea, i.e. chronic diarrhea, because when you have like diarrhea for more than 4 weeks, you're dealing with chronic diarrhea. And the framework for chronic diarrhea can be divided into 2 buckets, inflammatory or non-inflammatory causes. When it comes to inflammatory causes, you have to search for clues like fevers, chills, leukocytosis, blood, mucus, pills, tenesmus. When it comes to non-inflammatory causes, you have to divide into 2 buckets based on the stool osmolar gap, if it's elevated or not, greater than 50. If it's elevated, you have to think about osmotic causes like celiac disease, any cause of fatty malabsorption, lactase deficiency. If not, you have to think about secretory causes, diarrhea unrelated to food ingestion. Patients have diarrhea even at night, and cause could be gastrinoma, chronic infection like CMV, HIV. Collecting clues, we saw that this patient had actually no signs of inflammation or osmotic diarrhea, so secretory diarrhea became our focus here. But however, Rabi reminded that we have to be careful, Reza, because when dealing with patients with a past medical history or on medication that enable them to mount inflammation, maybe you don't see those signs, but it doesn't mean that you're not dealing with inflammatory cause of chronic diarrhea. And here, Rabi taught us that the CBC is actually telling you a story of chronic inflammation due to the thrombocytosis, which is could be a reaction to something systemic, more common causes, or myeloproliferative disease, less likely, and could be something like polycythemia vera. When dealing with non-annual gap metabolic acidosis, we have many causes, which we thought about diarrhea, renal tubular acidosis, Addison disease, saline infusion, and then as a reminder to look for the urinary anion gap. If it's negative, you have to think about the gut. So patients are losing bicarbonate. And then there's this girl that I really love. When you're thinking about elevated LDH, think about hemolysis, less likely because there were no increased indirect bilirubin, low heptoglobin, reticulocytosis. Think about also infection and less likely lymphomas. And then we saw that this patient had a chromogranin positive test. This is a marker of neuroendocrine tumors. Think about gastrinoma and lipoma. There's this mnemonic WDHA, watery diarrhea, hypokalemia, achloridria, but also something that I learned today, which was prostate cancer differentiation. Thank you, everyone. Such an educational case, and I hope to see everyone tomorrow on Global VMR.
Rafa, what time is it tomorrow?
It's you're asking Brazilian time or
anytime that you want to share. Just
okay, so
no,
it's,
actually
it's 2 p.m. It's 2 p.m. Brazilian time. I'm sorry, I can't.
No, that's perfect.
By the way,
thank you, everyone.
Rafa can also tell you the Zoom link by heart, probably for tomorrow's VMR case.
I love how Rafa is trying to end this, and we keep like bringing up questions for him. He's like, okay, everyone, they can call. So Rafa, how's your day, man?
Oh, it's great. It's great. Even better with you guys.